Hi, I'm Hannah, and I will be presenting on 4 different imaging techniques used for surgical guidance on prostate cancer based on the review journal, Technologies for Image-Guided Surgery for Managing Lymphatic Metastases in Prostate Cancer. I will begin by introducing the process of prostate cancer metastases and its relation to why different imaging techniques will be required for a suitable image guidance solution. Then I will be introducing the 4 types of imaging techniques along with their advantages and disadvantages. The main purpose of the presentation is to provide you with an insight into how the different imaging techniques will help in treatment of prostate cancer. So prostate cancer. It is the most prevalent cancer in males in Western countries. It is also the second mostly diagnosed cancer in Australian males, causing approximately 3,500 deaths every year. There are a total of 6 different stages in prostate cancer, which is shown over here. First stage T1 is when the cancer cells just started appearing inside the prostate gland and is undetectable because very minimal amount of obtrusion is present in the lymphatic anatomy. Second stage T2 is when cancer cells become detectable and are confined to the prostate without further spreading. The third stage, T3, is when cancer cells become locally extensive without spreading to other organs. The fourth stage, T4, is when the metastatic tumor cells break away from the primary tumor site and start spreading to nearby organs, such as seminal vesicle. But they have not reached the lymph nodes yet. We are going to focus a lot on the lymph nodes in this presentation. Although metastatic tumor cells may not necessarily first spread to lymph nodes, the reason why we focus on them is because more than 1/3 of prostate cancer metastases, lymph node is the first location of systematic spread. The lymph nodes that are firstly tumor drained are called the sentinel lymph nodes, abbreviated as SLNs in the slides. These lymph nodes are shown in the yellow region over here. The fifth stage, N, is when metastatic cells have reached many sentinel lymph nodes through lymphatic drainage and evades their immune surveillance. As the lymph nodes provide a hospital microenvironment, the metastatic cells will grow and colonize here. This provides the key difference between first 5 stages and the last stage of the disease progression. For the first 5 stages, the metastatic cells have not entered the vascular system or lymphatic system, which means they won't reach more essential parts of the body, such as the viscera and brain. At this stage, they remain in micrometastasis form, which is less than 2 mm in size, and it is particularly important to control it from further spreading at this point, because if it develops to stage 6 and onwards, there is no available cure at all. The current primary procedure for prostatectomy is called EPLND, which is short for Extended Primary Pelvic Lymph Node Dissection. This involves the removal of considerable amount of lymph nodes, as indicated in the green region shown in the previous slide. EPLND is non-specific in targeting malignant lymph nodes, and hence many unaffected lymph nodes are removed. Research has shown that when large amount of lymph nodes are removed, complications are much more likely to occur. Hence, it is necessary to develop a new procedure that aims to remove fewer number of sentinel lymph nodes. And this new procedure is called Sentinel Lymph Nodes Targeted Extended Primary Pelvic Lymph Node Dissection, which is abbreviated as SNL-TPLND. In this procedure, suspiciously malignant lymph nodes are removed instead of removing all lymph nodes in the affected area without precaution. Due to complexity of the pelvic lymphatic anatomy, it is important to define the location of the suspicious lymph nodes using imaging techniques. Hence, development of different imaging techniques that are suitable for different stages of the disease is much in demand. As explained before, from stage T1 to stage N, the metastatic tumor cells have not entered the lymphatic or vascular system at these stages, which means it would not be possible to use tracers to identify these cells. Hence, imaging agent that is able to simulate lymphatic drainage pattern is used to approximate the dissemination paths taken by these metastatic tumor cells. It is important to note that this technique does not specifically target metastatic cells, but identify potential metastatic cells and suspicious cells. If the disease has already progressed into stage M and macrometastases have entered the vascular or lymphatic system, they can now be imaged by attaching tracers to overexpressed biomarkers that are only carried by metastatic cells. The first three imaging techniques that I'm going to introduce are based on lymphatic mapping, with the first being radio-guided technique. In this technique, radio-labeled nanoparticles, known as radiocolloids, are used to simulate the drainage pattern. The most predominantly used radiocolloid is 99M technetium nanocolloid. It is a metastable nuclear isomer of technetium-99, which decays by gamma emission. The reason why this particular radiocolloid is used is because we want prolonged retention in SLNs so that the radiocolloid won't further migrate into higher echelon nodes. 99M technetium nanocolloid has a large mass, which is suitable to achieve such retention level. However, rapid visualization after injection is also desired. Due to its slow movement, it will also elongate the waiting time between injection and imaging. When they are injected into the prostate and slowly move to the targeted sentinel lymph nodes, the radiocolloid can then be imaged by detecting their emitted gamma rays. For preoperative imaging, 3D single-photon emission computed tomography is combined with computed tomography, which is called SPECT-CT scan. By rotating gamma cameras around the patient, SPECT scan constructs 3D images depicting accurate locations of the targeted SLNs. However, it has the limitation of being unable to depict the anatomic context in which the targeted SLNs are located. Hence, it is necessary to combine SPECT scan with CT scan. CT scan utilizes a rotational X-ray tube to shoot narrow X-ray beams through the patient's body with X-ray detectors located on the opposite side, which collects data of the internal structures inside the patient's body and process it into 3D images. By combining them, 3D images depicting targeted SLNs with anatomic context can be constructed. For intraoperative imaging, gamma probe, portable gamma camera, or freehand SPECT are used to detect gamma emission. The advantages for this technique is that it provides information on anatomic topographical coordinates of targeted SLNs in 3D context, which is essential for lymphoscintigraphy. And gamma probe is a well-developed tool that is capable of detecting in-depth lymph nodes that are covered by tissues, which is not achievable with some other imaging techniques, which will be discussed later. Another key advantage is that radiocolloid accumulates in the SLNs, which ensures that the surgical field remains uncontaminated. The disadvantage of this technique is that the accuracy level of identifying the correct malignant lymph node is not so great. The false negative rate is quite high. This means some patients will undertake unnecessary surgery of removing healthy lymph nodes and lymphatic tissues, which pose health risks. The reason why this occurs is likely to be caused by the fact that when lymphatic metastasis rate increases, the metastatic cells often clog the lymphatic channels, which change the original lymphatic circulation, and thus hinder the normal transfer of the radiocolloid. So as a result, the bypassed radiocolloid is transferred to the lymph nodes without metastasis. This will lead to a higher false negative rate. The second technique to be introduced is fluorescence-guided lymphatic mapping technique. This technique originally uses free ICG dissolved in sterile water as the fluorescent dye. It forms complexes with the natural protein and rapidly migrate through lymphatic system. Unlike radiocolloid that specifically target for SLNs, free ICG does not do that. It is capable of staining the entire lymphatic system, including lymph nodes and lymph ducts, etc. This technique is limited to intraoperative imaging because fluorescent signals are severely attenuated by overlaying tissues when the target is deep lying, as shown in the picture here. The tissue has to be cut open during surgery for the fluorescent dye to be seen. Usually, fluorescent signals can only be achieved at areas shallower than 1 centimeter from the body surface. Therefore, a new formulation is developed, which is a combination of ICG and 99M technetium nanocolloid. With this new formulation, the suspicious SLNs can be both detected by fluorescence camera as well as gamma probes during the surgery, and SPECT-CT scan is also available for preoperative imaging. For advantages of this technique, Fluorescent imaging offers real-time visibility and high-resolution image. So, if combined with a radio-guided technique, this will achieve great preoperative and intraoperative imaging results. It is also capable of generating individual tailored drainage template for each patient. Disadvantages that are going to be mentioned are referring to the original formulation. The new formulation will provide an improvement on all of these disadvantages. For the original formulation, the lack of specificity for targeting SLNs will result in large amount of staining, so a lot more SLNs will be identified as necessary for removal in comparison to the radio-guided method. And ICG lacks the retention level that 99M technetium nanocolloid has. And as mentioned before, preoperative imaging cannot be achieved due to tissue attenuation. Also, leakage of ICG will contaminate surgical field and increase surgical difficulty. The third imaging technique to be introduced is magnetic-guided lymphatic mapping technique. This technique much resembles the radio-guided technique. Instead of radiocolloids, it uses superparamagnetic iron oxide nanoparticles with a dextran coating as the tracer. It is abbreviated as SPIONS, which I pronounce as spions. These nanoparticles accumulate at the SLNs in the form of iron deposit, which turns the SLNs into a dark brown color. It will also change the magnetic properties of the SLNs, which make them detectable by using magnetometers. For preoperative imaging, iron-sensitive T2-weighted MRI will show malignant SLNs as negative contrast, as you can see on this image. They appear as black circles. If they have already developed into macrometastases, they will show up as positive contrast. For intraoperative imaging, magnetic probes will be used. In terms of advantages, magnetic-guided technique has a relatively high accuracy in results that are compared with EPLND, the conventional procedure that we mentioned before. Spions are also easy to synthesis and has high biocompatibility, which reduces potential morbidity of the patients. MRI also has high spatial resolution and excellent soft tissue contrast, which makes it suitable for detecting both micro and macro metastases. Disadvantages include the fact that spions are likely to be absorbed by macrophages, which could cause health problems. This effect is reduced by the dextran coating, but risks still exist. Another disadvantage is by the limitation of the intraoperative instrument. With current technology, magnetic probes are rather limited in terms of in-depth detection. The last imaging technique is the special one. It targets at the metastatic lymph nodes directly instead of approximating their path. There is a substance called prostate-specific membrane antigen, which is present on most prostate cancer cells. It is abbreviated as PSMA. In this technique, tracers that bind to PSMA will be used for imaging. The current mostly used tracer is 68 gallium PSMA, which decays by positron emission and can be detected by positron emission tomography scan, which is called PET scan. In combination with CT, it can produce preoperative images with great resolution. The preoperative image here is a PSMA PET CT scan showing intense signals from the tracer. As for intraoperative imaging, positron probes can be used. For advantages, the main advantage is that it targets at metastatic cells directly, which is health beneficial. For disadvantages, this technique is currently in experimental phase, waiting for approval. The availability of the tracer is also very limited. The tracer is also intravenously administered, so it can only detect macro metastases, but not micro metastases. So to conclude, lymphatic mapping techniques are the most reliable modalities for identifying micrometastases, while approaches targeting PSMA are most reliable for identifying macrometastases. As discussed before, integration between various techniques will lead to better outcomes, such as integrating ICG with 99M technetium nanocolloid, and the potential integration between radio guidance and magnetic guidance would lead to more accurate results for both preoperative and intraoperative imaging. These techniques have demonstrated oncological benefits and improvement from conventional EPLND surgeries, suggesting that further procedural and technological refinement are valuable and necessary. Due to various limitations on these techniques, it is important for research to be conducted for further improvement. In particular, we should focus on combining the lymphatic mapping and tumor biomarker targeted approaches to radically remove both micrometastases and macrometastases greater than 2 mm in size. Thank you for watching.